Congenital and acquired enzyme-deficient enteropathies associated with a decrease in the activity of key enzymes that provide membrane digestion and absorption of food ingredients are one of the most common causes of intestinal symptoms, as well as extra-intestinal manifestations of malabsorption syndrome of carbohydrates, proteins, fats, vitamins and minerals. It is important not to confuse this group of diseases with chronic enteritis or intestinal dysbiosis, since the management of patients is fundamentally different from the traditional administration of anti-inflammatory and antibacterial drugs to such patients. Today we will consider the most popular enzyme-deficient enteropathy, celiac disease. Celiac disease is a reversible atrophy of the mucous membrane of the small intestine, accompanied by impaired absorption and the development of malabsorption syndrome. Celiac disease affects 0.4 to 0.5% of the population, 80% of them are women. Damage to the villi of the mucous membrane develops as a result of a pathological reaction to gluten in the mucous membrane of the small intestine. The production of Agas to gliadin is significantly increased, which, in addition to binding antigens, destroy the epithelium of the mucosa. The genetic predisposition is due to histocompatibility genes HLA-DQ8 and HLA-DQ2 that ensure gliadin specificity of T lymphocytes and cells of the lamina propria. Cytokines released in the autoimmune response induce crypt hyperplasia. This is manifested by symptoms of malabsorption, diarrhea, steatorrhea, the occurrence of fats in feces, weight loss, polyhypovitaminosis and water electrolyte disorders. The clinical picture of gluten enteropathy is determined by a decrease in the absorption surface of the small intestine, a decrease in the synthesis of intestinal enzymes and cellular transport systems that ensure membrane digestion and absorption of substances. In typical cases, severe metabolic disorders and endocrine insufficiency are observed. The stool frequency reaches 6 to 10 times per day. The stool is light, mushy, foul, which indicates an impairment of fat absorption. Flatulence is caused by the action of microbes of the small intestine involved in the increased breakdown of substances that have not been absorbed in the small intestine. Abdominal pain occurs with an excess of gases or with increased peristalsis immediately after or before defecation. Extra-intestinal symptoms are a decrease in body weight, reaching 10 to 30 kilograms, general weakness, decreased performance. Half of the patients have hypooncotic edema due to severe protein deficiency. Almost all patients have iron deficiency anemia. In 40% of cases, endocrine insufficiency manifests in decreased potency in men, menstrual cycle disorders in women, uncontrolled thirst or polydipsia. Adrenal insufficiency. Sometimes there is an impairment of calcium metabolism, which causes muscle pain, cramps, signs of osteomalacia and polyarthralgia. 50% of patients with enteropathy have an atypical course of the disease with a predominance of extra-intestinal symptoms, anemia in adults, and delayed psychomotor development in children. Complications: ulcerative colitis, complicated by bleeding, perforation and deformation of the intestine, leading to intestinal obstruction and malignant tumors, of which the most common is lymphoma of the small intestine, which are the cause of death in 50% of celiac patients. The risk of cancer in patients is 100 to 200 times higher than in the general population. To make a diagnosis, a blood test for antibodies to gliadin and endoscopic examinations of the small intestine with biopsy are used. Treatment: The patient is obliged to follow a gluten-free diet for the rest of his life. Excluding products from wheat, rye and barley, that is, bread, pasta, semolina, flour products, chocolate, ice cream, mustard, canned meat, beer, sausages, mayonnaise, etc. Products from rice, buckwheat, corn, eggs, fish, potatoes, lean meats, beef, chicken, turkey, fruits and berries are allowed. The need for medical treatment arises with hypoproteinemia and edema. Then protein preparations are prescribed. With a lack of calcium, calcitonin and vitamin D are additionally prescribed. Iron, folic acid, and vitamin K preparations are often required too. In most cases, the prognosis is favorable with strict adherence to diet and adequate correction of malabsorption manifestations.